Please take your seats. With that, we come to our last presentation today. Dr. Peter McCluskey will be presenting 5 scleritis surprises. Welcome, sir.
Great. Thanks very much, everyone, and thanks to the organising committee for inviting me to be part of this uveitis subspecialty day. So I was asked to talk about 5 scleritis surprises, and these are the 5 things that I'm going to talk about: classification, epidemiology, associations, and the treatment. But I think the most the unexpected surprise is that there's been a real resurgence in research interest in scleritis around the world. There's many more groups now looking at their local results and the causes of scleritis, which is a really good thing. So Mr. Watson's classification really began close to 50 years ago, and it's one of the few disease classifications in ophthalmology that's really stood the test of time. I still use this same classification today as Mr. Watson taught me when I was his fellow. It is easy, it's clinical, it's anatomical, and it grades the severity of the inflammation, and dividing it between non-necrotizing and necrotizing, anterior and posterior, really helps you to sort out the likelier causes and how intense your treatment needs to be. This is an important paper that I'm just going to very briefly discuss on the epidemiology of scleritis, and it's sort of based on the really good computerized records that the NHS has. And this group from Moorfields went back and looked at 11 million patient visits to GPs over close to 20 years, and found that there were just over 3,000 cases where the diagnosis was scleritis, and they just looked at what's happened over that 20-year period. They couldn't really, because of the nature of the data, look specifically at what diseases systemically were associated with scleritis. But I think there are a number of important points for us. The first is that the incidence is falling, and it's gone down by at least 25% over the past 20 years. The prevalence is low. It's a very rare disease. There's basically about 1 case in 4 or 5 in 10,000 people, so it is a rare disease. Commoner in females, and being a female is actually a risk factor that was identified for developing scleritis. Non-Caucasian races have a higher incidence, and older patients or older individuals have a higher risk of developing scleritis. I think the most interesting things were that this study's confirmed a couple of things that we always were suspicious of, that patients who develop scleritis very commonly have been diagnosed already with some sort of inflammatory disorder, and that increases your risk of developing scleritis by a factor of 5 if you've already got a systemic autoimmune disease. And if you present with scleritis, you've got at least 2 times as higher risk of later on developing an inflammatory disorder. And the diseases that they found most commonly, the 3 commonest were GPA, Behçet's, and Sjogren's syndrome. But other important diseases were rheumatoid arthritis, lupus, inflammatory bowel disease, reactive disease, and sarcoidosis. And that really fits in with pretty close to our current sort of understanding of the common diseases that are associated with scleritis. Those being rheumatoid arthritis, anchor-associated vasculitises like GPA, seronegative arthritis, all forms of systemic vasculitis, inflammatory bowel disease, and sarcoidosis. And this is a sort of a fairly worldwide common group of associated systemic diseases. We also know that the more severe the scleritis, the more likely you are to have an associated systemic disease, in the same way that the older you are, the more likely you are to have an associated systemic disease. Necrotizing scleritis in all series in the literature is the least frequent pattern or phenotype rather of scleritis that we identify, but it's the one that's most commonly associated with systemic disease. And again, the severity of the disease determines how much or the likely treatment that you're going to need. So diffuse and nodular scleritis, you'll often get by with either either oral steroids or an oral NSAID. But once you've got significant posterior scleritis, panscleritis or necrotizing scleritis, or as one of the earlier speakers talked about, PUK associated with scleritis rather than uveitis, you almost always need combination immunomodulatory therapy. And we also recognise that patients who we know have a systemic disease, it often signals a sort of a vasculitic phase of the illness, and they're much more likely to need IMT as well. So this is a sort of a reasonable algorithm for how to think about the treatment of scleritis. If it's anterior and non-necrotizing, you can either trial an oral NSAID or a course of oral prednisone, and it's likely that that will control the treatment in the disease in the majority of our patients. Some of these patients need a steroid-sparing agent. It's uncommon for them to need a biologic or long-term immunomodulatory therapy. Patients who can't take systemic therapy, this is where, as long as you've eliminated infection, subconjunctival steroids are very useful. Patients with necrotizing disease or posterior scleritis, they need combination immunotherapy, so high-dose oral steroids. Usually we'll start our patients on methotrexate, and because we can access biologics much more easily now, we'll accelerate or escalate their treatment to a biologic fairly early. Although this paper's 40 years old now, it still emphasises a really important point, that necrotizing scleritis, if you don't treat it aggressively because of its risk of systemic vasculitis, there's a very high, up to 50% 5-year mortality rate without treatment. So necrotizing scleritis, in my clinic, we manage these patients in combination with a rheumatologist or immunologist. We actually have a rheumatologist who comes to our clinic every week, and the multidisciplinary team approach really is a very good way of managing these patients. As I said earlier, we start them on high-dose oral steroids. We'll add an additional immunosuppressive drug at the time we start them on steroids, or as soon as the workup's done, usually either methotrexate or mycophenolate. Rather now than adding tacrolimus or escalating to cyclophosphamide, if they don't respond well, we'll usually start with a TNF blocker, and if that doesn't work, go to a B-cell depleting agent like rituximab. The other important thing always to remember is about 10% of our patients with scleritis, it's caused by infection. In my country and in my city, the commonest sort of infection that we see is after pterygium surgery, where it's usually the Pseudomonas or some sort of a mold fungus. But it can follow trauma. Infective scleritis can be associated with systemic infections such as TB and syphilis. You can get severe scleritis after herpes zoster, and it can obviously spread contiguously from the cornea in patients with acanthamoeba and severe herpetic keratouveitis. And occasionally we also see patients who have severe intraocular inflammation who get a severe panscleritis as part of their disease. I've certainly seen that a couple of times now in herpetic retinitis and in patients with toxoplasmosis. Again, infectious scleritis, we really need to treat it aggressively. I'm lucky enough in our uveitis unit is that we have our own sort of on-call infectious diseases specialist that we can get to come to our clinic. She helps us treat our TB-related scleritis and pretty much all of our fungal and bacterial scleritises, and we use a combination of aggressive systemic therapy and high-dose topical and regional therapy, a low threshold for surgically exploring these patients to drain them, and several times now we've used this continuous subpalpebral infusion cannula of antibiotics to get on top of the infection. So in summary, basically, Mr. Watson's classification is still very useful clinically, and it's stood the test of time. Scleritis, although a rare disease and in probably most parts of the world becoming less common, it's still a really important disease for us to recognise because of its frequent associations with sometimes potentially lethal systemic inflammatory disorders and quite commonly associated with infection. And particularly in TB endemic regions of the world, TB is something to always think about in causing scleritis. And the best thing is that we now have better treatment. We're starting to get towards precision management where we can use biologics that actually target the underlying pathology. So thanks very much for your attention.
Thank you so much, sir. Any interactions from the floor, please? Please take your seat, sir.
We've got a few moments for some discussion, and I think there's a couple of interesting things we could talk about. The first is, could I ask Dr. Choi, do you tap all of your patients with hypertensive anterior uveitis, or what are your criteria for wanting to do an AC tap in your patients?
It's very important in the decision of the clinics. So I do taps for the treatment of cytomegalovirus, especially because HSV1 does not need PCR positive results. So I tap in cases of IOP elevation very high, like more than 40 or 50, and also when the patients accompanies higher recurrence rate compared to other uveitis cases. And thirdly, and I do the tap when patient shows the decrease in cornea endothelial cell count.
Great. And I might ask both of our speakers who've spoken about pediatric uveitis, do you see much pediatric sarcoidosis in India, and do you see much Blau's syndrome in India?
Yeah, so we've been seeing quite a few patients of Blau syndrome. In fact, what I feel is that quite a bit of the difficult granulomatous uveitis in children, because they are not being tested, probably is the reason why we are missing them. We've been testing and we've found, in fact, I have around 4 to 5 children with Blau who are on follow-up. The difficulty with Blau is that they are very difficult to control inflammations. We've had patients in whom methotrexate alone hasn't been able to control inflammation. We've even combined a mycophenolate, and yet they would keep relapsing. In fact, one of our patients is on a triple immunomodulation, methotrexate, mycophenolate. We've added tofacitinib now. So I think Blau is one entity that probably we are not diagnosing too much because the genetic testing for it is a little difficult to have for availability and financial constraints. But I think it is more in the population than we think it is.
Yeah. What about sarcoid? Do you see much pediatric sarcoid?
Not that much. But yes, in a focused uveitis practice like ours, we have patients, but I don't think there is so much of pediatric sarcoidosis. I don't know what Partho feels about this.
Okay. And I guess my other question would be, what do you do for the TNF poor responders, or people, patients who don't respond well to TNF blockers with pediatric uveitis?
So we've had some patients who haven't responded to infliximab. We've kept them on adalimumab, and of late we've started introducing tofacitinib. And like I said, etanercept was an agent that we've used for a patient who poorly responded to both infliximab and adalimumab. I think in that realm, it is better that we leave it to pediatric rheumatologists because they will be able to combine these agents better.
Yeah.
I think it requires a combination of agents like adalimumab, perhaps with one of the other agents like tofacitinib and etanercept. What would you feel?
Yeah.
We would try to avoid etanercept. And regarding tofacitinib also is the same. We need to take all these DMARDs, oral DMARDs combined with tofacitinib.
Yeah.
We generally won't combine biologic DMARD with small molecule inhibitor.
Yeah. But you guys are using JAK inhibitors now. Yeah.
Yeah, recently, I think we have published one series of tofacitinib in children, 10 children were treated with Professor Ramanan. So what we have realized that this is our first line treatment was first methotrexate, and then they responded because in India it's difficult to shift them to adalimumab primarily because of the cost factor. So we tried the children with a combined immunosuppressive like oral methotrexate and mycophenolate for quite a long time, and when they are not responding to that, then we shifted this patient to tofacitinib, and our response was good, but only 10 children. And coming, I'm sorry I missed this question, but the pediatric, I feel there is a significant overlapping in India, maybe in, I don't know about the other country, between the pediatric sarcoidosis and Blau syndrome, because many a time we suspect, and the diagnosis is not always possible, Blaus, and they come very late also.
Yeah.
So
I agree. I'm sure we've missed quite a few in my city, and I guess clinically the only clue we found that's useful is the Blaus kids not uncommonly have a family history, and secondly they often have a skin rash that's where it starts, whereas the sarcoid kids just have polyarthritis and uveitis. But I think a challenging area. Okay, that's my questions. How are we doing? Yeah. I think, it's actually, we've just nicely filled our session. So thank you very much to all the speakers and to my co-chairs, and thank you to the audience for coming along. It's been a really interesting session. Thanks very much, everyone.
Thank you, sir. Thank you, everyone.